we try to make it, inshallah, continuously in a weekly basis. And I just want to welcome all of you to participate and to suggest speakers if you like, to suggest anybody who would like to do something that interesting that for all of us to listen. I'm a pediatric cardiologist, but by training of Dr. Muhammad Tahir, who's our speakers, I have changed my mind to mental health more or less. So thank you for being here. Our speaker today is my friend and my partner, Dr. Muhammad Tahir. He's a co-founder of Kids Heart. He's the founder of American Wellness. We've been together since 2013, I believe, when he convinced me to join him in Dubai. And he's a American trained and pediatric psychiatry and adult psychiatry, American board certified, and he's a very well-known speaker in the community. And thank you for all of you. Dr. Tahir, please add any information I missed from your introduction. Thank you.
No, thank you. Thank you very much. Thank you for joining, everyone. And Dr. Suleiman, thank you for the nice introduction. You put me at a high scale, so I have to, do my best. This one is working, or that one? No, it's not working. Okay, so like this. Okay. All right. So welcome, everyone. Wednesday morning, and thank you for joining our meeting. Today we'll talk a very important topic, which is suicide. And suicide, basically, everybody knows, but I will just put WHO words, word by word. Suicide is the act of deliberately killing oneself. Risk factors for suicide include mental disorders, especially depression, and neurological disorders. So, in fact, who will kill themselves? For the person who did not go through this experience, this is very hard for them to believe it. In fact, this is not uncommon. I have asked this question because this question is mandatory in any psychiatric evaluation. If you are taking the American board and you don't ask the patient about the suicidality, they will fail you irrespective. I'm also the examiner and I know that. The two things, if you miss, this is definitely a fail. Number one is the suicidality. If you have a 30 minutes interview and you didn't ask about the patient is suicidal or not, no matter how good or how well kept together he or she is, you will fail. The second is like, of course, the psychotic, poor reality testing stuff. So in fact, when I asked some of the patients when they are coming and they look very well put together and everything, and I asked them, and their response was different. I can give you a couple of examples to understand that. One of them, they were saying, I heard that people kill themselves, but I cannot put myself in my mind how someone will kill themselves. This person was 20, 25 years of age, educated person, but he says, yes, I know this is a reality. I know this is happening and everything. But somehow I wanted to ask you as a psychiatrist, because you have seen people, why someone will kill. So for them, for the people who don't have this experience, or they don't have a mental illness, or they don't have this kind of problems in the mental health issues, they cannot even imagine or believe that. But in fact, the data is horrible. If I show you the data, I think it will be surprising. Not only surprising, but it is it is alarming. And the data is mostly from US, because they are keeping the data in more in in a detailed and regular way. So that's why we are having a mostly data from the US. Although there are researches here and there, but I didn't find more solid, and more believable data in the other part of. But globally, also CDC has some global surveys as well, which is almost comparable to this one. For example, there are more than 700 suicides globally, as per WHO 2021 report. This is not because of just the COVID, because also remember during the COVID, the suicidality was not jumped very high. In fact, it happened in 2022, as you can see in the lower slides. So the 700,000 a year globally is a huge number. I mean, thinking about 5 billion and stuff like, I mean, these are the successful suicides. I mean, how many unsuccessful or lower than that are many, and you can imagine that. So in the United States, there are one suicide every 11 minutes. This is, and internationally, there is one suicide every 40 seconds. So this is as per CDC 2022. In 2020, suicide was one of the 9 leading causes of death for people 10 to 64 years of age. And in 2020, suicide became the second leading cause of death in early adolescent 10 to 14 and the adult 25 to 34 as per CDC. The age-adjusted suicide rate in 2020 was 3% lower than in 2019. This rate increased to 18.3 per this age group 25 to 34 in 2022. So post COVID, there are a lot of complications, and I'm also seeing in my practice people are having a kind of vague symptoms of anxiety, depression, and the symptoms of like feeling blank or mixed symptoms. I don't want to go into this, not the topic. So anyway, post COVID, there are some complications. The purpose for me to bring it up is that so that we should keep in mind. I mean, there are medical complications, but as well as there are some psychiatric components which we cannot put finger on, but there is something going on. Now, going back to the suicide, why would people kill themselves? Why would people kill themselves? I mean, this is a big question. So I will just say a few things. They are not in the slides, but just pay attention. um, the major depression is feeling low energy, not want to talk. The symptoms are I mean, vague symptoms: not eating or more eating, not sleeping or more sleeping, and low serotonin level, and all these things, these presentations. There is a one very common and major component of the depression is the negative view of the past, negative view of the self, and negative view of the future. Think about if somebody is feeling, oh, I was useless, I didn't do much in my life, I'm the loser, and I'm I mean, feeling yourself as a very low, useless, or harmful, or something, whatever, because the guilt is a major part of it, and negative view of the future. So where the hopelessness comes. So feeling of hopelessness and helplessness bring the person to the point where it is very difficult to tolerate. You might have heard from the people saying that the mental pain is more difficult to tolerate than the physical pain. I mean, of course, again, I will go back to that. The people who never suffered the mental pain, I mean, yes, we all suffer, but not to the diagnostic level where it is a clinically diagnosable, I mean, lower level or fluctuating stress here and there. The people who did not experience the depression, they cannot know what is depression like. Unless you are clinically trained, you have seen people in and out, and every day in practice, you are seeing people. Seeing is believing kind of thing. So in fact, the depression is a major cause of the suicide. Now, there are other components as well. For example, misjudgment, like borderline people. The borderline personality people are happy, all sad, all good, all bad. And they try to, I mean, I never use the word attention seeking, because whenever somebody is doing attention seeking, this means the person needs it. So we cannot blame them they are attention seeking, because their mental capacity is not able to maintain or manage that. So they are asking some extra help. So it's not attention seeking. Actually, they are seeking help. Okay. So having said that, the person who tried to do something and thinking that he will not kill himself, or just taking pills, oh, these are just the pills, like toffees or something, and it will not kill, and momentarily, in the heat of the moment, or being angry or aggressive or something, they take the pills thinking they will not kill themselves, but at least the people will gather around and There will be some drama. They will take them to the emergency room and they will realize that, oh, what is the pain I'm going through? And they do that. And actually, misjudgment happens. And that was enough to kill somebody, overdose, and the person dies. So there are cases like that. Now, there is another category is impulsive. Like people become so much angry, they are angry at somebody else and they can be angry on themselves as well, so impulsively acting out something and they kill themselves. They go to the bridge or jump, or they have a sharp weapon, or they take the nose or something, whatever. So far the depression is the major cause. Then there are borderline misjudgment, miscalculation. Many suicide happens because of the miscalculation. They are underage, like for example the kids like 10-year, 14-year, although they have the concept of permanence of death, but still they can do some kind of things where is a misjudgment involved and they get killed. So the third is the impulsive. As I said, that the impulsively they become very angry, or they kill someone and they kill themselves because they feel, oh my god, what happened? The life sucks. I don't want to go in the jail for the rest of my life. I don't want to be, things like that. So impulsive. Then there is another very important component is the bipolarity. Bipolarity mean in the manic episode, people are very irritable, very grandiose. The diagnosis of manic is like when you are decreased need for sleep, lot of energy, lot of talking, expensive mood, spending lot of money, and risk-taking behavior. So when we call the risk-taking behavior, normally the person who is driving normally or drinking prudently or something during the manic episode, they can be driving like 160, 180 on a 100 zone, 100-kilometer zone or something, and they are driving so fast they kill themselves. I mean, this is suicide or not? I mean, you can, so it will be very hard to pinpoint, but medical illness, the manic part of the illness is responsible for causing this misjudgment and the risk-taking behavior and the death of the person. Also, similarly, overdosing of the drug abuse, substance use. Some of the people, when they are in manic phase, they feel themselves grandiose and they feel themselves they feel themselves as a invincible, and they think it will not kill themselves, but they overdose and they kill themselves. So misjudgment again, miscalculation. The manic stage killing is also happening. It's a known, and the manic people should be hospitalized. In fact, they qualify for the hospital admission. They should be until they are definitely they are. Kind of a level where they are stable and they are safe, they should be stay in the hospital under close supervision. So the next category is the psychosis, schizophrenia. Schizophrenia is a poor reality testing. As by definition, it's a poor reality testing, and it's a lack of judgment. Lack of judgment can cause people to kill themselves when there is a poor reality testing. For example, delusional people. The people who have a delusion, they are thinking the alien are going to attack the city and everything will be ruined and will be killed. They are so much scared, they kill themselves. I mean, they feel they cannot survive this, and it's a very, irony that untreated psychosis is very dangerous, and the schizophrenia is a big risk factor for the suicide as well. So, and there are other accidental things which happen, and there is a like a suicide which is passive. We use the word passive suicide. Passive suicide mean, okay, I don't want to kill myself, but I don't mind if something happens or something. So passive suicide is also noticeable, and we need to ask in the careful evaluation, psychiatric history, psychological patients before the patient leave. The mental health professional's responsibility is to make sure that this person is leaving my office, is this person is safe or not. If this is not safe, you have to do the protocol. You have to make sure the person is safe, in good hands, somebody is watching them, somebody is supervising them. So this is very important, because for the surgeon, they are afraid once they do the surgery, go home in the middle of the night, they have a nightmare about, oh, the bleeder opens. For example, somebody did the abdominal surgery, and at the night they have a nightmare, oh, the bleeder open in the abdomen and the person can die. So the psychiatrics, the mental health professionals' nightmare is that, oh, person go and kill themselves or do something like this. So this is so much important, and this is so strong that we need to be very, very careful and evaluating every patient. And looks can be deceiving. So please don't be deceived by the person well put together and everything. I have seen in my offices the directors, CEOs, and running the companies and everything, and they say, "Oh, I'm just coming in to see if anything wrong with me. I'm perfectly fine. My home is fine. My job is fine. I'm not stressed and everything." But when they come to my office, I'll ask them, "Did you ever have a feeling to hurt yourself, kill yourself?" I mean, sometimes they laugh or they smile. They say, "Doctor, why you are asking this?" I said, because the psychiatric evaluation is not complete unless I ask you this question. And there are, from time to time, there are surprises as well, actually. Very calm, very nice person, and the person you think is very well put together, when you ask them, "Oh, is there any time when you feel that life is not worth living and I don't want to live anymore?" You will be surprised. They say, "Oh my God, doctor, I'm very shy. I don't want to mention this, but seriously, I'm thinking like this. And when this feeling comes, it's very scary. And I'm afraid that I might not act on that." I mean, this evaluation for the last 20 minutes was going very fine. And I think he probably will not get any diagnosis. But this just one statement or one impression will change the whole scenario. You have to think differently. You have to ask many more different questions and evaluation changing kind of things. So that's why the point I'm trying to make is this one question is a must in any psychiatric evaluation. Know your patients. This is very important. Don't be deceived by those. So, passive, I was talking about the passive suicidality. Passive suicidality means sometimes people eat themselves, eat to kill themselves. They are eating, and they are not feeling happy, and they are feeling down and depressed, and they don't care, and they think that if I eat too much, it might kill themselves. And in fact, it can. We know that. Same thing is with the drinking. They drink and passively they drink more and more. They are not very clear in mind. So the clarity in the mind is not necessary for somebody to kill themselves. Sometimes the passive suicidality is they are not actively trying, but passively something happens, something. Passive suicidality also happens when people are sitting in the car and they keep the engine running and they are thinking, and then they say, "Okay, let me close the garage door and everything." And they might have heard that, "Oh, this can kill because the smoke will be collected, carbon monoxide and this and that." But they say, "Oh, it's not happening because I don't feel it," until they become unconscious. And then they cannot do anything. They cannot stop the engine, they cannot open the garage door, and then they die. So many different types of examples are prevailing and they are there. So this is a very, very important topic, hard topic. And I think if in the mental health profession, if somebody wants to not miss one thing and somebody wants to just know that what is the most important thing for me to remember is ask for the suicidality. Now I will go over the major depressive disorder because this is the most important component of this panel. So I will pay much more attention because many of the people somehow coming under the mood disorder or psychosis or bipolarity or anything. Depression is the most common cause which make the people feel hopeless, helpless, and eventually have them kill themselves. But any prevention, or the risk factors are more likely associated with the mental health disorders like depression, psychosis, bipolarity, and so on and so forth. So I'll focus the rest of the talk on the more on the depression than anything. I would like to leave more time for the questions as well. I'll probably finish in 40 minutes altogether, and we'll leave the time for the question answers because it's in this way I think we'll be able to help our audience to clear their concepts and make some impressions about like the mental. Yeah. So, what are the risk factors? I mean, people know that, but I just want to share with you the low income group. Also, it's sometimes reported, sometimes not reported, but this is a risk factor. History of prior suicide attempt is a major risk factor. Actually, in fact, in any psychiatric evaluation or in any mental health encounter, if somebody is saying, "Oh, I try to kill myself," even though you think it's a borderline and the person is just telling you to be as a, still it should be taken very seriously. If the person is saying that I attempted suicide, even though you feel it's a minor, and sometimes it's not uncommon for the patients to say that, oh, I wanted to kill myself, try to make a drama or okay. Can everybody hear me? Okay, all right. Oh, can you do that? Dr. Tahir? Yeah, I can. I'm trying. Okay, okay. Yeah, can you hear me? Okay, good. Thank you very much. So, prior suicide attempt is a very tricky sometime because sometimes the patient will, you feel like the patient is dramatizing and they are saying, "Oh, I wanted to kill myself." And when you ask, "How did you do that?" and they say, "Oh, with the common pain, I was scratching my wrist and look at my wrist, and in the wrist there are, the horizontal lines and the linear lines and stuff like this." You might think, "Oh, he's just joking and he's just borderline." No, it's not like that. The idea is creeping in the mind. When the person say, "I want to do suicide," although the attempt seems like a very, very minor, but this should be taken seriously and should be proper evaluation should be done for the future risks and the treatment should be done. So history of prior suicide attempt, family history of suicide is also very important and family history of schizophrenia can cause increased family history of mental disorders. And I mean, there are other data like minority groups, middle-aged men, rural living, certain occupations. We are not going in details, which actually there was a very detailed study about the which discipline of medical, like anesthetist, the top of the list. I mean, psychiatrists somewhere down third, fourth. The surgeons are like second, third, something like that. So there are a lot of studies in that regards, like different professions are highly vulnerable and vulnerable for the suicide attempts and successful completion of the suicide. So the identifying the lesbian, gay, bisexuals, personality disorders like borderline, cluster B is actually high risk factor in that, and followed by the cluster C and cluster A. I mean, the cluster B is the most, but cluster A and C is, I think, parallel with each other. Mood disorder, when we call it's a waste basket of all the mental health issues. Atypical mood disorders, bipolar 1, bipolar 2, mania, hypomania. So embarrassment is like a soft, but I mean, in certain cases, when it is associated with the other things, it can cause significant loss like grief, complicated grief, leading to depression and then leading to the suicide. So these are the some of the few. How do you do that? Okay. So then I will run down the list of the major depression just to recall for all of us. Major depressive disorder has the highest lifetime prevalence of any psychiatric disorder. Globally, major depressive disorder affects 300 million, which is almost close to 5%. Prevalence varies by age, peaking in 55 to 74. Internationally, depressive disorders are ranked as the single largest contributor to non-fatal health loss. You know, global total 50 million years disability and stuff. So early identification and treatment of early symptoms may prevent the development of full-blown depressive episode. Major depressive disorder is not a benign, and it is chronic and remitting, relapsing. So for depression, approximately 80% of persons report some level of functional impairment, and 27% reported serious difficulties in work and home life. National surveys have consistently demonstrated that more Americans receive healthcare from primary care providers than from mental health specialists. Because the primary healthcare providers are easy accessible, quick appointments, and they feel more comfortable discussing with them, talking with them. I'm okay. I'm just having some allergies. And the primary healthcare profession actually, we were actually even in the US. Actually, there was a whole program in which we are educating the primary healthcare professionals to identify, screen, and do the appropriate referral. In UAE, we also did that with the MOH. I worked with them for a couple of years, and we were taking the initiative and to train the primary health primary healthcare physicians to identify and to screen them. National surveys have consent, yeah. So percent of physicians' office visit with depression indicated on the medical record is 9.3%, which is a quite a bit. Percent of emergency department visits are 10.1%. 5 to 10% of patients with MDD develop manic symptoms 6 to 10 years after the treatment. So these studies are though controversial, but there is some consistency in that the people who are diagnosed depressed after 5 to 10 years of depression treatment, they might flip into manic depressive illness. And the responsibility was the SSRI. That's a different topic treatment wise. I don't want to go in that detail, but we need to be using SSRIs prudently for the psychiatrist. Especially I'm addressing that because the SSRIs are known to flip somebody, and especially this is a relative contraindication to the bipolar people because although small doses can be used in the bipolar, but relatively we need to be more careful for using the SSRIs and especially the high dose and undiagnosed or subdiagnosed people and stuff. So this is the DSM-5 criteria of major depressive disorder. I think people know that. I don't need to go in detail, the 2 weeks, the symptoms, and so there are other kind of depressions like complicators of major depressive disorder, seasonal affective disorder. Like in one season, the winter is more like prone depression, seasonal disorder, depression with mixed features, like in which eating more, sleeping more, and so on and so forth. So this is the criteria for the seasonal depression disorder. I don't want to go in that detail. So depression, mixed features of the depression. I mean, I can just review it. I don't need to go in that detail. So I will just touch upon a little bit on the major depressive disorder treatments. So biopsychosocial model, I think it's been much more stressed in the US and also in the other countries as well. The biopsychosocial model, depression treatment doesn't mean just prescribing as one SSRI, one pill of Zoloft is not enough to treat the depression. Biopsychosocial mean the biology, like biologically you have to see the histories, the living situation and all these things, the like the psychological status of the mind and everything, and the social component, which environment the person is living. So we need to consider all these 3 areas before making the treatment plan for the depressive disorder. So basically, we are saying that the utilization of the adjunct treatment, the depression is a lifestyle change. In fact, actually, the new concept and the new things is coming up. I know everybody's hearing that is the lifestyle. The mental health issue, the lifestyle changes. The medical health issue, the lifestyle changes. The eating disorder, the lifestyle changes. The lifestyle is very, very important, and we are much, much more stressing on the prevention, as well as if something happens, still you can manage your lifestyle in such a way that it is helpful to alleviate the symptoms of acute illness as well as to help prevent the future problems and things. So lifestyle, lifestyle, and lifestyle. Just like when we were buying the property, people are saying location, location, location. I would say treatment for the mental health, lifestyle changes, lifestyle, exercise and physical activity. So CBT, people know that cognitive behavioral therapy, interpersonal therapy, behavioral activation therapy. So IPT has shown to be effective therapy in the treatment of borderline personality, for affecting brain activity and neuromodulation and stuff. So maybe tried before changing medication. Adjunctive psychotherapy is very helpful for patients with depression when used alone or combination with the pharmacological therapies. Yeah, this is one study it was showing. But there is a general consensus in the American psychiatrists as well as the mental health professional psychologists that the depression treatment, medication and therapy treatment together is superior to the either treatment alone. So what I said, the depression treatment, medication plus therapy, diagnosed depression treatment, medication plus therapy is superior to the either treatment alone. So this is the bottom line. We need to see that. Okay. Though medications are very treatable treatment option, there are not only treatment options. Depression should be addressed utilizing holistic approach, as we said that. Okay, so these are the few concepts, like what were we thinking and what was our ideals or what was our goals. For example, in the decade of 1970 to 1980, there was a much more focus on the symptom reductions, so reduction of the symptoms, and we're thinking that that's it. And because at that time, as you know, there is evolution of the mental health illness treatment and the treatment goals as well. In 1990, we focus on the treatment response. For example, if we do the treatment, in a way, the treatment response was not only the symptom reduction, but also some function. So in 2000, when the novel SSRIs has come, like, Zoloft, Prozac, the first one, the Zoloft, the escitalopram, and so on and so forth, the focus was on remission because these SSRIs were much more effective in treating depression, anxiety, as well as having the least amount of side effect compared to the tricyclics, which we were using before the era of the SSRIs. So in 2000, the focus was on remission and normalization of functioning. So 2010, functional remission with improved quality of life. So we started talking about the quality because SSRI is like a very, very big change in the mental health treatment. And it's in fact, um, I'm not saying it's underutilized, but it's undervalued in my understanding. The SSRIs are undervalued. Actually, there was a joke. We had a meeting in Cornell. I'm talking about 2008. We're sitting in a quality meeting, and and one of our consultant, he is very funny, and he said that I think we should put the Zoloft in the Zoloft certainly antidepressant in the municipality water because there were so many cases were rising. That was also the time when there was some depression, the economy was going down, and so on and so forth in the US. So I mean, I'm not saying that underutilized because they should be properly used. They are the medication and they are the the active ingredients and stuff, but they are undervalued. So please try to understand, not underutilization, but undervalued. So now, I mean, more and more lately, we are thinking about not only increased functionality, but also enhance cognition, you know, the executive thinking, executive functioning, improvement, and the people who are depressed. And we have noticed, I ask from person to person, when they were depressed and when they come out of the depression, they actually visibly note that their brain is acting, working more efficiently and more effectively, and they feel themselves equipped with it. I mean, initially, even if you make it a constant or standard, that because of the depression and they are coming out of the depression and their mind is feeling some different, like the increased acceleration give you the idea of increased speeding. Even if you count that, still I feel this is a long-lasting effect when they improved from depression and this treatment after the treatment, successful treatment, they feel their mind is working more sharp. Anyway, this is my clinic. I don't have any research evidence or the paper or the standardized control study or anything, but this is my observation in my clinical practice. So goal and objectives of treatment should be discussed with the patients prior to the beginning of the treatment. This is very, very important. Actually, the psychiatrist should spend more time in educating the patient rather than prescribing a pill. Evaluation and prescription doesn't take much long. You evaluated and it fulfilled the diagnostic criteria and you decided that you are going to start on the medication and you prescribe the medication. But the compliance is very, very dependent on how much the information patient has. We have to spend time on the psychoeducation in order to make sure that the compliance is assured as well as the person understand, because the human beings, we run on belief. If we believe something, we'll do it. If we don't believe, we cannot take dictations, or we cannot take like things which we don't believe. So that's why i I have noticed the compliance is much more in the people who you spend more time with psychoeducation, explaining, answering their questions, and so on. Anyway, so normalization of the function, normal quality of life, so different there's a difference for different people. You know, the people understand differently. Their values are different, the ethnic group, geographic groups, and they're born, brought up, their genes and everything. So everybody is different. So it is not like one size fit all. You have to tailor made kind of treatment for the patients and the way you educate them. Goal and objective should be reassessed during treatment course, like at every visit, it should be reassessed. And also over here, I think it will be worth mentioning because there are studies, and you will see that in the SSRIs, there is a black box warning has started more than a decade ago, because there was a very famous study in which they have noticed that there was a slight increase in suicidality when the people were taking the Prozac and depression. So it is a very, very delicate and difficult to differentiate and assess, but the FDA decided to put the black box warning. But for the clinical purposes, what we need to know is that any time when somebody is very moderate to severely depressed and we are starting this person on SSRI, please keep close eye on that, because and there's a rationale. There's increased suicidality actually, as per data and as per in the literature. It says that the people who are very, very depressed, and when we start them SSRIs, there is an increased risk of suicidality in the first couple of weeks. And the rationale behind is that when people are depressed, usually they are anhedonic, they don't have energy. And you will not be surprised in some of the very, very depressed people when you ask them, I mean, do you feel life is not worth living? I don't want to kill myself or something. They say, oh, sorry? 2 minutes. Okay. So they are saying that I don't have energy to kill myself. You know, they say that if I have energy, this means that when the SSRIs are started, so there is an increased risk in the beginning. They should take care of that, and they should be assessed, properly evaluated. Okay, so choosing the treatment, I'm not going in that detail. Predictors are like, you know, just have a glance for the antidepressant response and the augmentation. The future directions are, you know, I will just say this one. There are a few treatments, new novel treatments, they are coming still. There's a ketamine, a lot of people are talking about, and there's minocycline treatment. The TMS is a HOFA, stubborn depression, the non-invasive brain stimulation, ECT. Actually, TMS is a modern version of the ECT, but still people are using the ECT, the deep brain stimulation, and so on and so forth. So inadequate and treatment failure, so you should be reevaluated. Screening for personality, psychotic symptoms, complicated depression, and you know, so this is the conclusion. You know, depressions are often disappointing, and they are the ultimate outcome can be suicide. So, Dr. Salman, I'm finished. Open for questions. Thank you.
Thank you very much, Dr. Tahir. You always amaze me with your presentation. MashaAllah, you offer, we need the whole day just to talk about this topic. And I like your statement when you say human run on beliefs. And that's why I think our team here, they believe in education, and they are all here. Please clap your hand, guys. Clap, clap.
Thank you. Thank you.
And one thing, you know, I was listening to Biden today, and he said there is 17 military guys, they kill themselves every day in the United States. I was like, this super, heroes, they still kill themselves like everybody else. And I learned something from medical school that, you know, thinking about suicide or attempting suicide probably is the biggest cry for help for any human being. So if anybody have tried or attempt or stated, that's the biggest way to ask for help from the community around us. So I think I'm going to leave the question, but I will have the question to Dr. Adala. She can introduce herself as well.
Thanks, Dr. Tahir, for your
Thank you.
talk.
Yeah.
I just had a question. Can you speak a little bit about the kind of the rates of suicide and their association with kind of social media use and gaming? Have there been any sort of statistics or data about that relationship between social media use and gaming and any, I would assume there's an increase in some sort of like suicide pacts or something like that, but is there any specific data that has come out about social media use and the association between that and suicide rates?
Yeah. This is the very, very sensitive part, and the suicidality is actually not usually associated with one thing or the other, as I discussed, and you know that the depression and the mood and everything, this is much more associated with somebody's mental state of mind. And how the mental state of mind changes, there are many different factors. That can be drug, that can be violence, that can be complicated grief, that could be psychosis, that could be social media. If you ask me personally, I definitely feel that there are direct and indirected effect on the suicidality, but I don't have a data, so I cannot pinpoint and give you any number. For example, I can share with you with the social media, like social media, the people are being bullied. The bullying is one of the major risk factor for depression. In the social media, people are like being abused and to the point where they develop some kind of mental health disorders and they kill themselves. So that's another thing. Now, the people are more and more alone and they are novelty seeking. This can affect their personality, the lifestyle, and everything, and leading towards the mental health problems and issues. So indirectly, there are a lot of reasons to believe that the social media and electronic media is increasing the suicidality indirectly, but directly, I'm not aware of. I mean, directly, for example, there are ideation, I don't want to name it and I don't want to pollute. I mean, you have seen some of the programs in which like they were banned already, and we are happy the authorities are taking action against that. Those are actually the things which teach the extreme behaviors, or that can cause some sort of overvalued ideas, if not the poor reality testing and stuff, and the people misjudge and kill themselves. But indirectly, there is a lot to say about it, and that's a whole different talk. I think if we need to address that, the social media and suicidality, social media, electronic media, and the suicidality. Thank you. Yeah.
This is May Yusuf. I'm a counseling psychologist. Thank you, first of all, for the presentation. It was really informative. And it's always a good refresh to talk about these things. My question is, is there any update with the hotline details? Did we know that? Because I remember last time we asked about if there is a local hotline for suicide.
Right.
Yes, and I think it's very important also to talk about the warning sign and the factors that can say that this person might commit suicide. But there are also some kind of rating scales. I know there is the Columbia Severity Suicide Scale, which has two versions, like one for screening and one full for practitioners. So the screening anyone can use. I know the policemen in the US and some part of the UK use it. So do we have something like that to use? Is there any protocol or guidelines locally that, like for suicide, how do we tailor our intervention and how we measure the severity of suicide? Yes, thank you.
No, thank you very much. Thank you for bringing this up. These scales are helpful. There are quite a few for the suicidality, but I can tell you the successful suicides, actually, maybe you remember there was a study done, and the successful suicide, majority of people, the data shows that they have visited their psychiatrist within 30 days. And when those psychiatrists were interviewed, the psychiatrist said that this patient was very good in imitating, and they were saying okay. And when they looked at the notes of at that date, the person who committed suicide, the note says that the patient denied suicidality. He was a cheerful, and they were talking about going on vacation or something like this. So the point I'm trying to make is that when the people are very, very depressed and hopeless and helpless, their reality is not impaired, and they are very smart in that. And if they have so much depression, hopelessness, helplessness feeling, and they want to kill themselves, they want to make their plan succeed. So it can be very difficult. I mean, scales can be helpful. I understand that, But the person who is in that kind of mindset, they will answer the question. They know that what the scale's meaning. They can answer that. But still, I mean, we should use the scale. In my understanding, the most powerful tool all we have is the training and the structured interview. Nothing face-to-face interview, not on the Zoom. Zoom interview doesn't count, to be honest with you, for the suicidality. It's not that effective. Face-to-face structured interview is the best tool. Yes, of course, we should use the suicidal tools and the question. We use the simple depression tools, anxiety scales, and so on and so forth. Of course, we can do that. So, but as I said that, I mean, and also I did not say in today's talk, I say in every talk, two things actually. Believe in yourself. Gut feeling. Gut feeling is a joke, but it's not a joke. Gut feeling comes from, I have a one video, maybe if people like to listen to that. The gut feeling is that, our mind working automatically. So it is getting all the informations, all the receptor five senses and the internal, coordination and executive functioning and everything. So sometimes we cannot put finger on, but the thought comes in our mind. So that is we usually call my sixth sense or gut feeling or anything. You need to believe that and you need to verify that. If you have a gut feeling, oh, this person is saying I'm not suicidal and everything, but somehow I don't know, it feels like it's not safe. So believe in that. So believe in yourself. So this is number one. The second thing is eyes cannot see what our mind doesn't know. So we need to know all these things, what's happening, like when the patient is depressed, when the patient is psychotic. So proper diagnostic evaluation is the key to avoid this kind of mishaps and things like that. We can do our best. So believe in yourself and try to assess suicidality at every visit. Thank you.
Yeah, sure. Dr. Samra is our psychologist here. He will ask a question.
It wasn't unmuting. So, yes, okay, yes. Thank you so much, Dr. Tahir, for such a lovely presentation. I've been following it through before night.
Thank you.
I wanted to ask this, but I'm giving out that I wasn't allowed to make. One of the things, the role of parental involvement here in safeguarding their child from committing taking any extreme steps. Why am I asking this question is in my clinical practice, I'm coming across this. And children are complaining that their parents are not listening to their symptoms, whatever they're explaining, whatever they're doing, and they are going through some type of self-harm. So I'm at a loss there as well because the parents are not making contact with me. I'm trying to contact them, but they're not making contact. So how to deal with a situation like that, where there is a culture there is non-acceptance. So especially with the girl child.
Mm-hmm. Right.
So,
yeah, it's very difficult, and I understand what you are trying to say exactly. I think it will be case by case basis. There will be a cases where there is a, the patient is being helped with the psychotherapy. They have a minor symptom. You can educate the parents. See, this is very important for them to continue the treatment, and it's very important to keep an eye on them. And what I'm telling my audience and my colleagues, we should tell to the parents as well. Believe in yourself. We'll tell the parents if they have some kind of this kind of suspicion or some kind of instinct or anything, please bring it up and don't just brush this off. Believe in yourself because normally we assume they are smart people, they are accomplished, they are well educated and stuff, and if their brain is saying something, this means there is something going on, and bring it up to the mental health professional and sort it out. So this is I'm saying where there is no immediate suicidal risk or anything. So if there is a suicidal risk, depending upon the severity and depending upon your information about the case, you can tell the parents and tell them, I mean, black and white, I mean, I'm worried about them, and this is the thing. And if there is any risk or anything, the most important thing is saving a life. So call this hotline, call 999, and take him to the emergency room immediately. Call me, send me a message, let me speak to the doctor in the emergency, because in the emergency room, the doctors are may not be very well trained in mental health cases, and you have to tell them, because they can be easily, I mean, they can be easily, just not taking care that much. You can tell them that this is my under my treatment, and this is my observation, and this is how it should be done. So we can raise the concern to the mental health, to the emergency room doctor, and then they can take care from there, and this patient should not be. So in those cases, when there is a evident suicide risk, they should. Somebody is trying to interrupt me. Okay. So when there is a definite, you feel there is a definite suicide risk, then you should not let the patient go alone. There should be somebody, responsible person should take care of that person, or you have to call the ambulance. If God forbid some situation happens, in the adolescent is alone or the adult is alone in the office, and you reach the family is not reachable and nothing, and you cannot let the patient go alone if you think there is a clear risk of suicidality. You have to, this is the responsibility of the clinician actually, to call the 999 and take them to the emergency room, because you cannot leave the person alone. I hope I answered the question, Dr. Sama. Anybody else?
I have a good friend here who keeps shutting me up, you know.
Please tell me.
So I just want to tell you about a story. A few days back, 3 days back, at 11 o'clock p.m., I received a call from a psychologist telling me, what do I do? I have a patient who just called me right now and want to kill himself. So I said, I'm glad that I'm a pediatric cardiologist, but I guess I can't help with that. So just call the police. Is there any other way to handle this? And the number was 999. And I was right when I said that. I just guessed what it was.
Right.
Is there any way to handle? How to handle? Because I heard from another person who commented, maybe you shouldn't call the police right away. Maybe you should have called the family or the friends, or what is the best way to handle this situation?
Okay, let me tell you the real scenario actually what happened, and this was in US, but I think we can replicate the model here as well. So there was a patient and who was a known mood disorder case and on medications and everything, and he called one of our team members, psychologist in Cornell, saying that, and this was actually happened in the EC evaluation center, and I was happened to be there, and when she was on the call, and I asked her to put on the speakerphone, and I was witness for that. So when this person called and this person said, I didn't take the medication for 2 days and now I'm feeling very, very bad and I want to kill myself and everything. So this psychologist, she was a pretty, I mean, experienced 4 or 5 years, but she was no seeking my. I mean, I was the in charge for the EC at that time. So I was helping her. So what I told her is that ask him. I was asking her because I didn't want to show that I'm in the call as well. So she has a good relationship with this patient. So first I asked her to ask if somebody is around in the room, keep him engaged and ask him where he is, which part, which floor, which building, and everything, and keep engaging and everything. So he was a good relationship with her, and she kept her on the phone. And I was guiding her this one question after the other question, just keeping engaged and things. And we call the 911 from the other line, and we give the location and everything. And we were lucky enough that the police arrived when he was still on the call with the psychologist. So this is scenario I just shared with you. This is an ideal situation, and then the police came with the ambulance and they took him to the hospital. When they go to the hospital and everything, they, he was a bit upset that why this. But after that, in the next session, he was very glad and he was very, very thankful to psychologists bring flowers. So these kind of things can happen. So the common sense is not so common, but it prevails. So we keep engage the person, try to find if anybody is around here and try to get, because it can be very, very risky, because during your conversation, if person lose the temper or can be triggered with some simple minor thing, no confrontation, nothing, just, I mean, try to be polite and, I mean, I'm not saying agreeing, but try not to be in a conflictual situation, do not make them angry and engage them as long as you can. And then if you feel that it is a real risk, you can call the police. I mean, you are saving the life. I mean, you are saying on the one hand, you are saving the life. On the other hand, you are losing a 1-2 hours emergency response. I mean, you have to measure the risk versus benefit. I mean, for example, if the person is on the high floor, 32 floor, there's a balcony and there's a door open and everything, and he's on the phone with you, you should call immediately, I guess. So those kind of things. And I think there is no hard and fast rule. Every case is different. I mean, in this case, the one I showed you the example, there was a clear non-compliance with the treatment and the worsening of the symptoms and the poor judgment and all these things. So all these things matters. But I think the family, if it is immediate available or anything, this is fine. But we cannot trust if the patient is in Dubai, the family is in Ras Al Khaimah, they're on the vacation, and we call the family first. If the family is coming to Dubai, how long it will take, and so on and so forth. So human life safety prevails. This is the top urgency, and this is the top priority in any case. So I would not hesitate. If I feel that the person is suicidal, I would call the help immediately.
Thank you, Dr. Tahir. Last question is not for you, but for the audience, and whoever can answer this question is going to get a prize. So out of this audience, if you know the answer, just write it there, and you know whoever answers first will get a big prize, inshallah. Dr. Tahir mentioned in his lecture the south side ratio in globally, the number globally. Anyone from the audience on the Zoom know what was that number? No, per minute. How many per minute? Not for you, say from the audience. 1 in 11 minutes. No, that was 11. 1 in every 40 seconds. This is the Najwa Asaka. Thank you, Dr. Najwa. I think you got it right. That's globally. The 1 in 11 second was related to US. But globally, I believe it's 40 seconds. That's what Dr. Tahir said. So Dr. Najwa won the prize, and inshallah, you're going to get it very soon. We'll talk to you. Okay?
Thank you. Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Thank you. We recorded this.